Welcome everyone to the Seeing is Believing Western Pacific Region webinar. Thank you so much for taking the time to come today. The theme of today's webinar is strengthening eye health systems, and I'm pleased to introduce the presenters we've got today. One is Sally Crick, who most of you know is the Seeing is Believing Programme Manager here at IAPB. We've also got Guan Chang'on, the Senior Programme Manager from Orbis International North Asia. And we've also got Niming, who's the Acting Programme Manager, the Fred Hollows Foundation, China. So in terms of the agenda today, we'll start off with an introduction from Sally. Then Guan's going to do her sort of PowerPoint presentation. Then Niming will do her one, and then there'll be a sort of a Q&A section where if you've got any questions on any of the presentations or any of the issues raised in the presentations, then you can ask them for ask the presenters directly. In terms of housekeeping and admin, you should all be able to see my screen. I've shared my screen. If you have any questions at any point, if you can put them in the, write them in sort of the questions section, which on the panel on the right-hand side of your screen. And then what I'll do is at the end of the presentations, I'll share the questions to the two presenters. And I'll look at what sort of, depending on how many questions we have, I'll either sort of manage to get around to asking every question, which we might be able to because of the number of attendees we've got, or I might sort of theme the questions depending on what sort of is the most popular kind of question. When people are not presenting, and for all of the attendees, your microphones will be on mute, and that's really just to make it a better quality webinar. And if you have any problems, you can email me, but also do know that we're recording this webinar, so we will make it available after the webinar. We'll put it up on the Seeing is Believing pages of the IAPB website. So once again, thank you very much for attending. Thank you ever so much for the presenters as well for sort of spending the time that they've done preparing the presentation, and also for being willing to kind of share their experiences of strengthening eye health systems. So thank you very much, and I'm going to hand over to Sally now for the introduction.
Welcome everybody. Can I just sort of repeat what Susan has been saying, which is I'm really pleased that everybody's been able to join us today for this webinar. As you know, this is a new sort of initiative for Seeing is Believing this year. And this is the third one, so I think Susan and I are getting a little bit more relaxed about it and managing it all and things. But many thanks to everybody for participating today. I hope you enjoy it, and do fill out questions in the chat box if you have any for either the presenters or just generally for Seeing is Believing for Susan and myself. Because if these go well, we will be sending around a questionnaire at the end. We will be looking to repeat this with a different theme again later if people have found it useful for themselves and things. And also at the moment, as you've all seen, we have sort of kept the geographic areas into separate groups because we weren't quite sure about quality, but also for time zones to enable people to join something that is more convenient for them and things. But obviously, everything is sort of possible for change in the future and things. So although we've got a rather small group of us today, we can always think about different ways of organising this so that we have larger groups and things. Anyway, welcome everybody, and I'll hand back to Susan now.
Thanks, Sally. Okay then, let's start with Guan Chong, the Senior Programme Manager for Orbis International North Asia. Okay, Guan, over to you.
Good afternoon and good morning, everyone. I'm Guan Chong from Orbis North Asia office, the project manager of SiB Chair Project. Chair Project has been implementing health system strengthening approach since 2013. So I would like to share my experience and lessons learned from this project. I would focus on two elements of WHO health systems, leadership, governance, and service delivery. But I would also brief how the other four elements work in CHAIR project. As you can see from this page, the figure on the left, leadership and governance is at the core of the health system. It is vital for the impact of project. CHAIR project has three categories of strong partnerships with combined resources and competences. First, we have four international NGOs. These international NGOs have different strengths to work together. For example, Orbis support for clinical part, Brian Holden Vision Institute Foundation support for optical and low vision, Helen Keller International support for screening, and Perkins for early educational intervention. Secondly, with the strong support from provincial government, cross-sector partnership was established among health, education, and disabled people's population. For example, a joint official document was issued to these sectors at all levels before the project official launching in June 2013. We also established cross-disciplinary collaboration, such as between ophthalmology and neurology, and between ophthalmology and the NICU for ROP. With the strong leadership, we were able to shape government health insurance policy to cover strabismus surgery in this project, which was not covered because it was classified as a cosmetic surgery. Another impact of this element in CHAIR project is we also able to conduct a joint regular event with education departments on child health promotion, such as on National Eye Day, World Sight Day, and Children's Day. In CHAIR project, we invited hospital leaders to engage in project activity through such as annual meetings, study visit, field visit, so they provided better support to other health system elements. For example, they allocated more staff and funds to support screening. So the project make the project easier. Next slides, please. Next slide. Yes, thank you. As for the second element of health systems, from the second one. The second is about people. Yeah. Yeah, as for the second element of a health system, from the left figure you can see people are at the center of health systems. In most hospitals of CHAIR project, the number and the competency of mixtured staff are not a big issue after training and clear job description assigned to each staff. In hospitals with limited staff, one person carries multiple tasks in the beginning of the project, such as a reflectionist or optician, or a nurse is also responsible for supervising teachers to do school screening and for data entry. After some time, when the hospital leader realized the service volume increased, they were happy to allocate more staff. Staff motivation is also important in CHAIR project. This is done through professional development. For example, training opportunity for new knowledge and skills, recognition of other achievements through rewarding meeting, and more patient, more income, etc. Next slide, please. The second vital elements of health system in CHAIR project is provision of a wide range of child eye care services. This complex project is different from classic eye care projects. It shifted from just a focus on treatment or surgical service. CHAIR project provides a full range of eye care services, including prevention, clinical interventions, optical and low vision service, rehabilitation, and early educational interventions. This aligns with one of our governmental policies, which says combination of medicine and education, and collaboration between families and communities. One of service delivery is to generate demand through screenings and continuously massive eye health education and promotion in public, such as among teachers, children, and parents, and at special events by using a range of printing materials, videos, health talks, etc. In CHAIR project, the most important was we established a two-way referral and the service pathway among multidisciplinary and multi-sectors at all levels, including hospitals, schools, communities, and families. You will see in the chart on the other slides. And in CHAIR project, quality, safety, and efficiency assurance are important components. These were done through every steps, for example, from different trainings to screenings and referral to service, such as surgical, optical, low vision, and early intervention. Quality assurance first should compliance with our government regulations, and then also international NGOs recommendations. And next slide, please. This is a flow chart about two-way referral and service pathway used among multi-sectors and multidisciplinary, such as health, low vision, rehabilitation, education sectors, and professionals in CHAIR project, from screening in communities and families to service provision such as initial diagnosis, treatment, service in local country hospital, and if necessary further to higher level hospitals for complex treatment and management, and also if necessary then to low vision clinics or rehabilitation or even special education if medical service would not help. For example, a 4-year-old blind boy due to ROP could not talk and eat himself. In old days, the eye doctor would tell the family there was nothing they can do to help this boy. However, according to the referral pathway in this project, the eye doctor referred the boy to an optometrist, then to a low vision clinic, and then to a special educator. The mom thought her boy had an intellectual problem or autism. However, the boy became talkative and learned to feed himself after his mom was trained in how to take care of him. Also, the family was advised to go back to low vision clinic and educators regularly for assessment, and the boy would be able to attend school when he reached school age. So this kind of holistic service provision helped strengthening other health systems elements, such as leadership and governance in this project. Next slide, please. Coming to the fourth element of health system. Health financing is something beyond eyes. In CHAIR project, we were able to advocate government to change health insurance policy on strabismus surgery. The project also practiced tiered pricing for spectacles and provide free glasses and subsidized surgery for the poor children. Financial burden and social stigma of congenital cataract children reduced significantly after they had surgery. We also started to encourage hospitals to think about exit strategy after the project ends. For example, encourage them to use profit from optical service to subsidize school screening and the poor in terms of sustainability. The project also attracted government attention, so there is a plan to do research for new policy on school eye health. Next slide, please. About health information system, the fifth element of health systems. In SHARE project, we have an online project project management system and electronic school-based screening database to ensure timely collection, analysis, dissemination, and utilization of project information and data. Information sharing among all project-related personnel in the project, such as NGO partners and local cross-sector partners, through monthly meeting, study visit, email, phone call, and in-country social media apps such as WeChat. This helped local partners a lot in fostering their ownership of this project. Next slide, please. The final elements of health system. We have less challenges because of availability of low-cost quality optical and low vision devices in the country. So that's these are all what we would like to share from SHARE project. And thank you.
Thank you so much, Guan. That was a really interesting presentation, and one of the things that I always, I've heard this presentation a couple of times now, and just the sort of the leadership and the governance element within the project that you've sort of supported with the hospitals really does kind of shine through in sort of all the different areas. So thank you, Guan. That was a really interesting presentation. Okay, we'll, rather than take questions on this one now, we'll go on to Guan's presentation, but if you do but if you do have questions, could you put them in the questions section or the chat section in the right-hand panel, and then we'll do the questions at the end. Okay, let me set up the next presentation. Okay, then over to Niming, who's the Acting Programme Manager for the Fred Hollows Foundation, China. Okay, Niming, over to you.
Thank you, Susan. Hello, everyone. My name is Niming from the Fred Hollows Foundation China program. It is very glad to have this opportunity to share our work, especially on health system strengthening with you. Susan, next, please. There are 5 parts of my presentation. The brief of seeing is believing phase 5 in the Mongolia project, the background of health systems instruction in China and in Mongolia. And the third one is why we focus on health workforce and service delivery, and our strategy against challenges we faced. And last, I will brief the impact of our strategy. Next, please. SiB Phase 5 Mongolia project is aimed to improve policy and practice for providing quality rural eye care services by establishing a comprehensive rural eye care model in Mongolia and delivering a replicable model for advocacy at the national level. There are 5 elements of this project. One is about human resources development, to build the capacity of eye care professionals in Mongolia in order to provide quality and sustainable comprehensive rural eye care services to local people. The other one is addressing priority disease effectively through regular outreach screening, treatment, community participation, and eye health promotion. Next, please. in current situation in China, usually there are 3 levels of service providers. You can see this the picture on this slide. Tertiary, which is prevention level in China, which will treat all types of patients with all level of severity and a large number of operation and our patients. And the secondary level is in China we use it as the county level hospitals, which will treat out an inpatient primary inpatients. And also for the primary level in China is township or village levels. But we face some challenges such as in this appropriate number of patients in tertiary and not fully utilized of country level hospitals. Not mention lower utilization of primary level health clinics. This is not only for the other disease but also for eye. Yeah, next please. As mentioned previously, we would like to increase utilization of county level hospitals and township clinic village doctors, but the capacity of eye-related medical staff is not good enough to provide this kind of eye care services as needed. There are about 400 eye doctors in Inner Mongolia, but less than 20% of them can perform cataract surgery. Most eye doctors are located in the urban centers. There are about less than half of the 90 county level hospitals in Mongolia can provide the basic sight restoration. Many patients have to wait for the waiting surgeries from provincial hospitals. There is also significant lack of refractionists and other medical staff. DR and refractive error are diseases in need of early detection and referral, as well as eye health education. Community level eye health play a key role in this. According to the local census, there are less than 10 retina specialists serving nearly 25 million people in Inner Mongolia. Health workers at the community level has no complete knowledge to provide primary eye care education to their people. The community level referral services lacking due to the limited training and faculties for providing support for the eye care service. This is a crucial need to increase the knowledge and skills at the county and the community level to facilitate early detection of eye disease. Yes, please. Next, please. Susan, next please. In our project, there are different proposed functions of each level service providers in the eye health system. For the tertiary centers, we would like them to can provide trainings and technical supports and solve complicated cases. And we also aim to solve 50% avoid blindness in secondary level hospitals and provide the screening service in communities or schools. Also can provide primary eye care training for the primary level staff. And for the lowest level, the primary level staff, we would like them to be able to conduct health education and coordination and assist the screening and also provide follow-up and referral services for their people. Yes, please. Next, please. In order to build the capacity of each level medical service provider, the project designed different kind of trainings for different purpose and different target groups to meet local needs. For example, to increase the capacity of performing cataract surgery, we have series training courses. The first age, depending on the basic skills of trainees, from 1 to 3 months cataract surgery training, including lecture, web lab practicing, and observing cataract surgery. After that, several times hospital-based cataract surgery training will provide to them. This kind of training will be provided by the Technical Support Center, which is provincial hospitals in trainees hospital. After this training, the local county hospital will be able to provide cataract surgery provides for the local people with essential equipment supported. Meanwhile, the training manual was also developed also developed, and this will help the trainee and trainer to provide the high quality cataract surgical training. And another example is about the primary eye care training for medical staff from township clinic and village doctor. The project developed primary eye care training manuals for trainers and trainees. The topics including basic eye disease, which village doctors should be able to screen and provide the primary treatment, and all kinds of trainings are integrated with local government training program for village doctors. So once the project finish, this training will continue to conduct it among the health system. And the primary eye care toolkit also provides to them, including eye chat, torch, health education materials, and the primary eye care manual. The village doctors can use this manual to have very simple which one they need to refer and which one they can give a very simple treatment. Yes, please. Next, please. This is for the health workforce in the health system strengthening. The next, I will brief some service delivery. Due to the limited capacity of local health services providers, lots of essential eye care services do not exist in the primary level, such as not only in the primary level, but also in the county level, such as professional refraction and cataract surgery. And and old people always think this is normal if it is normal if I can't sing and if I am old. So this all the misunderstanding or misunderstanding is we will address in our health education. Yes, next please. And also in China, a lot of public hospitals are willing to wait people in the hospital rather than go outside to find more people to treat. So based on this challenge we faced, we encourage our county level hospital partners to go out to do screening, and this can increase utilization of facility. This can increase utilization of doctors. As you may know, Chinese government launched National Basic Public Health Service project, which is designed for addressing these primary health issues. It's including 12 services, which is establishing health record, health education, patient with chronic health management, for example, type 2 diabetic. Eye health record is required in established resident health record, but due to lack of capacity, the eye information remain unavailable. The project equips village doctors to fill the eye part of health record for each person in the community. And also, I can give you another example of our service delivery. Like in the Mongolia project, we have DR prevention component. And we think if we have the diabetic patient club, as a membership will provide be free, and will also they will get discounts from examination and treatment. The diabetic patient club will provide the health education to the members, and also they can use this opportunity to share their own experience, like how can they control their blood sugars and how can they maintain their regular eye checking by themselves. Next, please. And next, I will brief the impact of our project. Within establishing full-function 3-level prevention blindness network based on the existing health system, such as integrate primary eye care into primary health system, will increase the effectiveness and the cost-effective and also the sustainability of this project. Okay, next, please. Okay, thank you for your listening. This is all my presentation. I'm willing to answer any questions.
Thank you, Niming. That was really interesting, and I'm really sort of interested in how you managed to look at the situation where you don't have people who are kind of going up through the system and at the appropriate level, and how the project is sort of managing to get people treated and sort of referred at that appropriate level, and then sort of screened at the appropriate level and then referred up. So again, that's really interesting. Thank you so much. Okay, if you have any question for Guan or Niming, if you can put it in just type it in the chat section. I'll just type where, so you can see where I'm typing questions here. So if you have any questions, if so if you type your questions in the either the chat section or the questions section on your right hand panel, if there's anything that you want to know a little bit more about, or if you have any specific questions on any aspects of the iHealth system, if you'd like to type your questions now, and then I'll put your questions to our presenters.
Okay, and while everybody's thinking about that, it's Sally here, and I thought those were two excellent presentations, sort of explaining to people who don't understand the issues in China of how these two projects have been working hard to improve services and increase the general utilization of services. And I have two questions that I will verbally ask now. Perhaps for the CHEER project, so to Guan, one of the very innovative things from that project, which I was sort of very interested to learn about, was how you are improving the local ownership, both by the staff working with the children, be that, screening of school children or working with some children with special needs, was the use of the social media platforms and how you're sharing not only between the NGO but also then with the local hospital staff and people providing services, but also with the families and with, I think in English we would call them support groups, but I'm not sure if this is the same and what you're doing there. So maybe you could tell us a little bit more about how you're using social media. And Niming, I was particularly struck by your slide, which had the 4 columns of your capacity building plan or overview for the different levels of staff at the tertiary, secondary and primary levels. But you'd pulled out management as a separate key issue that needs to be addressed in Inner Mongolia. Maybe you could tell us a little bit about whether this is a common way that Fred Hollows looks at the capacity building needs, or whether this is something that you have developed as this project has gone along, or specifically for Inner Mongolia, or whether you think that would be something that would be useful to think about for capacity building in other locations or situations. So maybe Guan, if you could tell us a little bit more about social media, and then afterwards, Niming, if you could just talk us through a little bit more about how you see your capacity building overview, or that plan where you had the 4 pillars on one of your slides. Anyway, Guan, if you'd like to just chat us through social media.
Yeah, thank you, Sally. This social media we found in this project is very powerful. We usually use 2 Chinese ones. One is WeChat and another one we call it QQ. So we have different groups. It's really, yeah, maybe you are right. We can call it support groups. Like we have a WeChat group with family, like parents of ROP. So the parents will send a video or ask any questions in the group. And in the group, there is a project coordinator, special educator, and reflectionist or optometrist. So anything when the parents ask some question, there will be somebody answer. And also we have groups like we have a management group. So it's all for project managers. And we have group for teachers for who doing school screening. And it's a big, very big group. So every time when teachers have any questions on how to conduct school screening or how to upload data, they will ask in this group. Then sometimes our project staff or reflectionists or even some other teachers will answer their questions. And we also have a WeChat group for reflectionists only. So it's like a technical group. So this group is really, we were able to educate these people on what we are doing in this project. And because we have some larger groups, so including everybody relevant to the project there, so because everybody talking different part of the project, so in this group, the members, they understand not only what like in reflection, not only they know the project management. So this kind of information sharing really makes all group members understand more about project. And because they understand more, then they were more willing to contribute, to support each other. So we found out this kind of information sharing or communication improving really helped a lot, and it's gradually more and more. So we had we had a mid-year meeting just last week. Look back compared to 2 years ago, we feel these project managers, they understand everything about their challenges, their solutions. So we are so happy. And also like another social media, QQ, because these two Chinese social media app has different strengths. Like one is QQ is good for we are sharing our project documents, like we conduct meetings, so we have materials, PowerPoint. We have sometimes we also have some not only about eye health promotion, also about like we have PPTs from India, like for community eye health. Then we share all of this in our QQ, so everybody can access, can download it and they can ask questions on how they work in this. So I really feel this helped us a lot in this project. Not only sometimes the phone call or email is really not enough, but because we have this the two social media, and we were also able to conduct our monthly meeting among NGOs, and also we can conduct a monthly meeting with all project hospitals. So it's so convenient and very efficient social media apps. We are lucky to have this.
Okay, Guan, thanks ever so much. I mean, this is really very exciting. Certainly, I've not come across another project which has embraced social media, and I know in some ways you were sort of almost pushed into it because of the large coverage, the large number of partners, hospitals, special schools, refractionists, optometrists that you were sort of having to come into contact with and looking for feedback from and things. So I think the way that you've embraced social media has been really very, very exciting, and I do think this is really a great learning on how to embrace social media and not to sort of be sort of hesitant to try it. And I love the way you have involved the parents and enabled them to get some inclusion for the users of the service or their families. I think that's great. Yeah.
Okay, thank you.
Okay, so anyone else who's got questions for Guan, please type them in, and we'll now go across back to Niming. If Niming, if you could just explain the slide that Sarah has now got up on your screens, or with the sort of 4 pillars of capacity building.
Yes. Why we have one pillar called management capacity is because as we think the I department is only one department in the whole hospitals. So we think if we want to like a screening activity or health education, so they need multi sectors cooperation. If we can provide the kind of management capacity training for them, they can support us better and also can raise their awareness of this project. And also we think because a lot of Chinese, like county level hospitals, they don't have very advanced experience on how to manage hospitals. They only use some traditional ones. As an international NGO, we want to introduce some new concept or new management tools or approach to improve their management way and make more utilization of their resources. This is for one. And why we divide these 4 pillars is because we think primary eye care capacity is one of the most important for our rural eye care model, because they play key roles in the referral network, which is highly recommended by the health systems training approach. So we want to do more work with the primary eye care capacity, because they made the first hand to reach the patient in their communities. So what can they do and what kind of information they provide is important for the local people, because these people made the most trusted person in their community for their seeking medical service, especially for eye. Yeah.
Sorry, I was on mute. I was talking away. Just to follow up on that, who actually conducts the primary eye care training? Because obviously it's very important, as you say, but who actually delivers it to the clinics in the rural areas?
Yes, it's because in China, the China government usually provides this kind of training for maybe once a month or twice a year. It's a different. It depends on different topics and it depends on different situation. And when we integrate our eye care into this routine systems, we invite county level hospitals to do this kind of training. And also we will provide the training of trainers for county level hospitals for how to provide this kind of training for the primary level staff.
Okay. Yeah, great. I think that's one of the important things, is for the primary level staff to meet the trainers from the local county hospital and to realise that there is you know, a whole department, and that they've met some of the individuals working in that eye department, so that they have confidence to refer their you know, the people they've found at screening that need to be referred to the county hospital. They sort of feel that they know a bit more about the service providers at the county hospital level if it is the county hospital staff who do their training sort of events. I think that's really good that they are able to assist with those primary care training. Great.
Yeah.
Okay, do we have any other questions from anyone? I think we might have a question here. Okay, so I have a question from Anha. So the question is, some of the topics of the training provision for the program are very interesting. Would like to ask if we can reach the training or adapt the training program for our projects in Vietnam. For example, TOT for Vision Center Manager it's appreciated if we can organise the similar programme for our vision centre. So maybe, do you want to talk about how...
just can they share it?
Yeah, just kind of share about the a bit more of the topic of the training provisions. So then Anha can think about how they can adapt it for the their vision centre.
Yeah. Yeah. So that was to Niming. Can you share your vision centre management tool? Would you be prepared to send it to An Ha in Vietnam?
I think for our vision center management is because vision center, as mentioned, I think Guan also mentioned in chair project. It's I think it's a kind of not new things in the it's kind of new things in the county level hospitals. So we provide this kind of like how this vision center operation and what's the resource request and also what's the organization chart for like this, and how is the inventory management, things like that. It's kind of comprehensive how to run or operate vision centers, also including very important community marketing and how to do the school screening and how to do the follow-up, can attract students come back to your vision center to get the glasses.
Okay, thanks, Niming. We'll be finishing in about 5 minutes or so. So if you have any final questions or burning questions, can you type them across now so we can have a chance to ask the presenters before they finish?
Can I ask one question for Niming?
Yeah, please, go ahead.
About the primary eye care training. Because I noticed you are training different people like health women or BPF officers and questions. So my question is, which kind of trainee you are training for? Like, these are used for different tasks, or is the same task they were trained for?
I think it's for different tasks. For example, if we train the community health workers, such as village doctors or township clinic doctors, the training content or topic will including the basic eye disease and how to refer what kind of eye condition should be referred, and when you refer, where you will refer, and the county hospital will provide what kind of service for them. It's kind of two-way referral. And if we train the school teachers, it's more like the how to do the test of viral acuity and what kind of health education they provide. We also developed a health education training manual for school teachers. It's all about interactive games with children, and they will understand how to protect your eye, how to prevent refractive error, such like that. And if we provide training for the Disabled Persons Federation officers, because in China they have a very strong network from the provincial prefecture, county level, and primary level also in the village level, and they also have the similar task about to treat cataract patient or find the cataract patient. So we will cooperate with them about how to find cataract patient and use their network for us. It's a different contact for different target group.
So for Disabled People's Federation and the village doctor, they all screening cataract patients?
The same purpose is find the cataract patient, but for the Disabled Persons Federation persons, they don't need to understand some eye disease. They only know what is cataract is okay. The screening activity was conducted by the hospitals.
So that's good. And which one is more effective?
We think the village doctors is more effective because they not only have the network, they also have the reputation in this area for the for medical services, and also they have the willing to do this.
Thank you. Because in Chair project we started to use Disabled People's Federation community workers, because we thought the same. They have strong network, and HPI really insist to use them. But finally, we found actually in 18 places, only one county is very effective, but the others is the village doctor is better. So that's why I want to ask you this question. Thank you, Yimin.
Yes. I think it's more important is what you want them to do, and what's the motivation of them. And also, I think in Chair, if we because you have the low vision component, and I think Disabled Person Federation will a good operation partner about to tackle low vision, because they also have the same task by the government.
Yeah, but they have very the technical knowledge in the community is not as good as what we expected. But in the county level, it is okay. But when go to community or village, it's different. Okay, thank you.
Welcome.
Thank you. Thanks for that question. That was a really interesting discussion there. And then we've got one final question from Lien from Helen Keller, Vietnam, who's also asking Niming about the Vision Center management training. Also interested in having a look at the training materials, but also asking who do you have for the trainer for those Vision Center management training?
Usually we have two kind of trainers. One is like peer trainers. We will invite other project successful training vision centers manager to share his experience, successful experience of how to successful manage vision centers. And also we cooperate with another kind of colleague, not college, university, or this kind of Tianjin eye hospital. They have very strong vision center management training capacity. So we will cooperate with them and discuss with them, and we developed some training for our county level hospitals. So it's two different trainers.
Okay, thank you, Niming. Okay, I think we're going to stop there. So thank you once again, all of our both of our presenters, for Sally and for everyone for attending. Hopefully, this sort of learning and sharing is something that people find useful. And as Sally mentioned, I will be sending out a survey either today or tomorrow. So it'll be really good to hear from people what you felt about the webinars. Did you find them useful? Did you find them interesting? And so we can think about, are we going to continue to do them in the future? And so please sort of keep an eye on that. I think Sally just wants to say a final couple of words.
Well, just to say thank you to our two presenters for being the first people to present on the new Seeing is Believing webinars. Thank you very much to both of you. I thought they were both very interesting, and I think it's great that you've taken the time to put your thoughts down into this sort of PowerPoint presentation and then talk us through it. I certainly found it very interesting, and I could ask lots and lots more questions, but obviously we've run out of time now. I think I've also learned a lot, and I hope other people have too, and I look forward to being in touch in the future with you all. Anyway, I'll stop now, but to say a big thank you again to Susan for organising all this. It's quite a lot of behind the works organisation to get these up and running. So thank you very much to everybody who's attended today. Thank you.
Thanks a lot. And there are some thank you messages coming up on the questions as well, so we appreciate that. I'll forward them to the presenters, and if you do have any other questions sort of afterwards, then do contact us and we can get you in touch with the presenters. So thank you once again to the presenters, and we'll be in touch with the survey in the future.
Thank you.
Thanks all. Bye.
Bye.